So we basically touched on a little bit of the theory behind ultrasound, and now we're going to talk about the application. And just like I said in the last section, if you've already done this in lab, some of it is probably you're like, oh, done that. That's the idea of what we're doing this year, front loading it in the lab, so you don't have you have some idea of it when we start to talk about the theory. So our learning objectives for this section, you should be able to describe how frequency, intensity, and duty cycle work together to create a treatment directed to a specific tissue area. What a standing wave is and why it's potentially dangerous, the thermal and mechanical or non-thermal effects of ultrasound, and what are the clinical applications of that. Comparing US parameter settings for acute, subacute, and recovery applications, stating the contraindications and precautions for ultrasound, and the advantages of applying ultrasound underwater. So when would you do it? How are you going to make that decision in the clinic? When are you going to use water as your coupling agent? So thermal versus non-thermal effects of ultrasound. Continuous ultrasound is going to have a thermal effect. The increased tissue temperature is affected by the absorption coefficient and the tissue type. And like I said before, that collagen-based tissues or tissues with higher levels of collagen in them absorb more. It's the intensity and the frequency is also going to affect how much the tissue increases in temperature. Post ultrasound, which is the non-thermal version, is the effects come about through cavitation, microstreaming, and acoustic streaming. We'll talk about what those are, and increased intracellular calcium. So non-thermal ultrasound promotes cell function and tissue healing. That's something you can't feel. So sometimes you will run across a patient in the clinic that'll say, "Oh, I had ultrasound one time and it was really helpful for blah, blah, blah." They're not going to feel accelerated healing and improved cellular function. They might feel warmth, but it is as a sort of pain management technique, ultrasound is not usually your choice. You're usually doing ultrasound for increased tissue healing, or maybe for a deep heating effect, to warm up for something else, but you're not generally using ultrasound to address pain. So if somebody says they had pain relief from ultrasound, good for them. But that's not one of the indications that we're generally talking about with ultrasound. So the physiological effects of thermal ultrasound or continuous ultrasound, and of course, we abbreviate that as CUS in the chart. So we'll say CUS to this part of the body times 10 minutes at this power and at this frequency and this intensity. So that's how we're going to chart it. But the cellular effects also happen during thermal ultrasound, so you get heating and cellular effects, and then non-thermal, you take out the heating. So continuous ultrasound accelerates metabolic rate in the cells, can reduce or control pain and muscle spasm. And like I said, we're not usually going to choose it just for that, for pain, but the heat part of it can reduce muscle spasm. It can alter nerve conduction velocity through the heat, like we talked about with superficial heat applications. It can increase circulation and it can help increase soft tissue extensibility by allowing those collagen tissues to absorb the energy. Okay. So, unique to ultrasound versus other heat modalities, it's more localized and you can go deeper. So, when we're doing superficial heat application, you're kind of doing a general area. You're going to put a hot pack on a general area. But with ultrasound, you can localize it to the tissues that you want to direct it to. So, that's an advantage if you're using it for thermal effects. Continuous ultrasound is well suited to tissues with high absorption coefficients. So tendons, ligaments, joint capsules, fascia, all of them have a relatively high collagen content. And so, yay, let's use continuous ultrasound for those. Maybe. Ultrasound being applied to the posterior knee in this picture in conjunction with an extension stretching force that can help with soft tissue extensibility. So this person probably has a knee flexion contracture, and we are trying to stretch those tissues out in conjunction with doing ultrasound. So a lot of times doing two things at once can be super helpful. So whether they're doing an active stretch or in this case, they're doing a passive stretch with weight and doing ultrasound at the same time, that can be helpful for improving soft tissue extensibility. I have worked with people or with contractures where ultrasound was part of the treatment. So I worked with one person who had elbow flexion contractures, basically from sitting immobile for too long and underlying disease processes. And we would do ultrasound, stretching, manual therapy. And the difficult part was the person lived in a skilled nursing facility and used a wheelchair for mobility. They got to the point where their elbows were so contracted they couldn't propel the wheelchair themselves, so they needed more assistance. So by using a combination of continuous ultrasound, manual stretching, and manual therapy, we were able to increase his range of motion enough that he could propel the wheelchair by himself. So that's a big difference for this person. It gives them some level of independence that they didn't have before. So that's a really good application of ultrasound with other techniques that worked out really well for the patient. For non-thermal or pulsed ultrasound, it alters cell membrane permeability, which accelerates tissue healing because nutrients have to get in and waste products have to get out. If it's more permeable, it's easier. There are studies that show evidence of stimulating activities associated with tissue healing. Ultrasound stimulates those activities. It increases intracellular calcium, which stimulates the production of proteins. We want that when we're healing. Um, it increases skin and cell membrane permeability. It increased macrophage responsiveness, and we talked earlier in the quarter about the role that macrophages play in the development of scar tissue and healing. So that's important. And it increased the rate of protein synthesis by fibroblasts, who the fibroblasts are the cells that are creating the new collagen. So that's great. And these non-thermal effects are thought to be achieved through cavitation, acoustic streaming, and microstreaming. Most of the studies that show the effects of non-thermal ultrasound use a 20% duty cycle, like I said a little bit earlier. So there aren't a lot of studies with a 50% duty cycle. So 20% duty cycle for non-thermal effects. Cavitation is where little bubbles form, little micro bubbles form, and they form microcurrents. Stable cavitation is the one that has the effect in non-thermal ultrasound. Unstable cavitation, the bubbles get so big that they pop. And these are like micro bubbles. These are, you have to see, microscopic. You can't see them with your eyes. But that microstreaming, that's part of what increases the cellular permeability. So stable cavitation is gas bubbles in the ultrasound field expand and contract without bursting. And that's thought to increase cell membrane permeability, which allows ion and molecule diffusion to aid in tissue repair and healing. Pretty handy, right? So unstable cavitation is when that you get excessive expansion of those gas bubbles and it causes implosion and significant temperature increase in that micro area. And it's thought not to occur at therapeutic ultrasound intensities. If you had higher intensities, it might, like if you're using sonar to detect whatever in the sea, you might get unstable cavitation. Eddy currents around gas bubbles that are oscillating due to cavitation, those are those microcurrents. And the steady circular flow of cellular fluids induced by ultrasound um, larger than microstreaming, which are the little microcurrents, are thought to alter cellular activity by transporting material to and from various parts of the ultrasound field. So if you can get stuff moving, that's kind of the idea, and get stuff moving in and out of the cell more efficiently, you can accelerate healing. So that is one of the indications that we'll use for ultrasound is we're using it to accelerate healing, particularly for pulsed ultrasound. non-thermal. The non-thermal effects happen at thermal ranges as well, just so you know. Contraindicate or indications, clinical indications for ultrasound, soft tissue shortening, like I was talking about with my former patient, pain control sometimes, dermal ulcers. Somebody has skin ulcers. Ultrasound can help improve healing. Surgical skin incisions, as long as you don't have plastic parts underneath it. It's one of the contraindications. So if somebody has a knee replacement, don't use ultrasound on their knee. Tendon and ligament injuries, fractures, carpal tunnel syndrome, phonophoresis, which is where we use the sound waves to push medications in transdermally, usually anti-inflammatory medications. So, I haven't seen phonophoresis used in a clinic for years. And if anybody works in clinic where they use phono, tell me. But it's not very commonly used these days. I'll just tell you. So phonophoresis is the application of ultrasound with a topical drug for transdermal drug delivery, and it basically physically pushes the medication into the skin. So some studies show both heat and mechanical forces from the ultrasound are helpful. Um, you need a media that can penetrate the skin. So, like dexamethasone is an anti-inflammatory that's used in iontophoresis and sometimes phonophoresis. It's an anti-inflammatory medication. Again, I haven't seen this too much in the clinic recently, but there might still be somebody out there doing it. So, for direct application of ultrasound, you need a coupling gel or underwater. Um, the sound head, you want to choose the size appropriate for the area. So if you're doing a hand or a foot, use a small sound head, like a 1 centimeter sound head. If you're doing like a shoulder, maybe a 2 centimeter sound head. If you're doing like a low back, you might want to go to a 5 centimeter sound head. Those are usually the sizes that you see, but choose a size appropriate for the area. The area that you're gonna ultrasound, the field of your ultrasound should be 2 times the effective radiating area of your sound head. So if you think about that. If you're using a 2 centimeter sound head, you want to do a 4 centimeter area. And the speed is 4 centimeters per second. So if you have a 4 centimeter area, which is approximately 2 inches, you're going to take a second to go across that. That's pretty slow, right? You've seen people doing ultrasounds really fast, running the sound head super fast across the area. You're really not getting the best effect, so you want to go slowly, 4 centimeters per second. So it's going to take, if you're using a 2 centimeter sound head, and you're doing a 4 centimeter area, you're going to take a second to go across that 4 centimeter area. So pretty slow. So here's sort of our clinical decision-making tree, and this is from the text. So impairments, if you have soft tissue shortening, you generally want to use thermal at 100%. You're going to use, if you have a relatively superficial problem, 1 to 2 centimeters, you're going to use 3 megahertz. Starting at around 0.5 watts per centimeter squared. And if you're doing a thermal application, you are going to ask the patient after about a minute, do you feel heat? And if they don't, you're going to turn up the intensity a little bit. The duration of treatment is going to be 5 to 10 minutes for 2 times the effective radiating area. So if you have a big area, you're going to have to do it for longer. So if you have a 10 centimeter area, you're going to have to do it for longer because you just want to do 5 to 10 minutes for 2 times the effective radiating area. So just think about how that works. If you're trying to accelerate tissue healing, and decrease inflammation, you're going to use non-thermal pulsed ultrasound, or PUS. 20% duty cycle. The depth is going to be the same frequency, and you're going to be in between 0.5 to 1.0 watts per centimeter squared. So this is a nice little decision-making tree you can use in the lab or anytime. just to kind of decide on your parameters. Once you get used to them, if you're doing it fairly frequently, and I got to tell you, I can't remember the last time I did an ultrasound, except in lab. But the I worked at a clinic where we didn't do them very frequently, and for the last 15 years, and so um, this might be something that you keep just to look at, just to remind yourself of the parameters. But if you're doing it all the time, you usually remember that. So you can do like you're still going slowly 4 centimeters per second, but you can do little curly cues, you can zigzag, however you decide you're going to move the head, whatever feels most comfortable to you. I think probably, even though it's not very difficult, the most difficult thing about ultrasound is just kind of getting the physical management down, and that's what you get to practice in lab. So hopefully that makes sense to you. Contraindications and precautions, as usual, malignancy and pregnancy. Those are always contraindications for just about every modality. Um, Central nervous system tissue. So if someone had a laminectomy where they had their lamina removed of one of their vertebrae, one or more of their vertebrae, you don't want to do ultrasound over that area because you're ultrasounding directly over central nervous system tissue without a barrier in between. Joint cement. So if somebody has a cemented prosthesis, hip or knee replacement, you never want to do ultrasound because it jostles the cement and can break it up and cause them to have a revision. Any plastic components, and there are plastic components in hip and knee replacements, over a pacemaker or any other implanted device, just like most modalities. If somebody has thrombophlebitis, which is blood clots in their veins, you don't want to jostle them loose so they can go up and lodge in your lungs or your brain. That's not good. Eyes or reproductive organs, I cannot imagine the situation where you would think about doing that, but don't do it. Precautions, if somebody has acute inflammation, if you do a thermal technique, you might make it worse. Makes sense. The epithelial plates in an immature human, someone that's not fully grown, when they're before their plates have closed, you can do it, but you want to be cautious about it. Fractures, again, it's an indication and a precaution. So usually if you're using ultrasound for bone healing, you're using a specific device for that, not just a regular ultrasound machine. Breast implants, why would you ever ultrasound someone's breast implants? But don't do it. Or, think about it. So contraindications and precautions. I always wonder like how those came about. Like why? Why would you do that? But be familiar with especially the common ones like joint cement and plastic. Do you see anywhere on here where there's metal implants? No, you're okay if it's just metal and not metal and plastic. And there's no joint cement. If you just have a metal implant, it is okay to ultrasound over a metal implant. I don't know how comfortable it'll be, but if somebody has a pin in their humerus or a plate in their ankle, you can ultrasound over that area as long as they don't have joint cement or plastic parts in there. So a potential adverse effect is you could burn somebody with ultrasound if you don't move the sound head. So the sound head should always be moving while it's touching the patient. Standing waves, and we'll talk about the standing wave in a second, and cross-contamination or infection. So in the good old day, I'll call it the good old days. In the olden days, we used to too long ago, we used to keep ultrasound gel just in a warmer in the clinic, and then the infection control people came around and said, nope, 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 you can't do that. You have to have separate, sealed, sterile ultrasound gel applications for each person. So we got these little packets you have to open. So, your mileage may vary. You want to clean your equipment after you use it, obviously. So standing wave, if waves going in and reflecting back are in sync, the reflecting wave superimposes on the incident wave, causing higher peaks. So you get higher intensity and potentially very high intensity and You can burn somebody with that. You want to keep the sound head moving, and that prevents a standing wave. If you just hold it still, the wave's going to go in, and the reflected wave can amplify and cause a much higher intensity than you want. So the way to avoid a standing wave is keep sound head moving. We're going to document the area treated, frequency, intensity, and duty cycle, treatment duration. We're going to say whether it was underwater. You don't usually have to say if you used coupling gel because if it wasn't underwater, then it's assumed that you used coupling gel, and the patient's response to the intervention. Especially if you have to terminate the treatment early because the patient had an adverse response. If the patient says, "Oh, that feels stingy," or zappy or something like that, stop the treatment. If they say it feels warm, yay, that's what you want if you're doing a thermal treatment. If they say, "I don't really feel much except you just moving the sound head on me and you're doing a non-thermal treatment," that's fine. But document that and then the next time you go around, the other thing, of course, you always want to document is why you did it. So you did ultrasound for deep tissue heating. You did ultrasound to accelerate healing. You did, so you want to say to increase circulation and accelerate healing. And whatever the reasons were that you did it, you're going to document that as well.